Good evening, and thanks for logging in. I just want to go over a couple of disclaimers before we start. I have conflict of interest that are very marginal to this, and you can read them over here. This is a long webinar, actually, so we will try to skip over some of the details and go right to the meat of the question. I've been doing advanced laparoscopy for many years, more than I dare to admit. But I am also a reproductive endocrinologist and infertility specialist. So half of my practice is infertility and in vitro fertilization. So the focus of my surgery is clearly reproductive surgery. In 2006, the intuitive representatives in Boston pointed out to me that we had, in fact, in-house one of the first Da Vinci robots built. We had acquired it in 2000 for cardiac surgery, and it had since fallen into disuse, but it was started again by our urologist in 2005. And so very early in 2006, I was persuaded to go on to this quite intimidating unit, and I have to be very honest, I've never gone back and I've never looked back, and I have witnessed an important improvement of technology over the past 12 years, which I think has proven me right in that early choice. At this time, I don't practice conventional laparoscopy anymore, even though I am a fully trained laparoscopic surgeon, and frankly, every procedure that I do perform robotically, I can perform laparoscopically, but I will endeavor to explain to you why I think my professional choice is a practical and ethical choice. I don't think I have to explain to this audience that we consider currently open myomectomy as a second-line operation. Minimal invasive myomectomy has taken first line. The studies looking at the safety of laparoscopic myomectomy and the reproductive safety of laparoscopic myomectomy over open myomectomy have been there for over a decade and a half. And so this is out of the question at this point. It's a medical fact. It remains, however, also a medical fact that myomectomy does not change depending on access. Myomectomy is a microsurgical operation in terms of minimal tissue impact, hemostasis, respect for tissue, minimal use of coagulation, use of sutures that is judicious but also respectful of the peritoneal surface. And this is a central point of what I'm about to say, because the reality is that conventional laparoscopic myomectomy, which is still widely practiced in Europe as well as in America, is an excellent procedure. And if it's done with microsurgical technique, and if it follows the same technique that you would use with open surgery or with robotic surgery, then it's absolutely the first line procedure to consider. In all other cases, however, this is not an ethical approach anymore because of the availability of robotic myomectomy. Robotic myomectomy, which, by the way, at this point is a procedure with a 15-year safety record. The first paper already published is in 2004. So the trial on that one started in 2003. So it's not a new procedure. But those of us that have jumped on it over a decade ago now have achieved a significant number of cases to draw experience from and to share experience from. Why would I only offer robotic myomectomy to my patients? The thing is, first of all, I am an academic surgeon. And I train surgeons every day. I've been training surgeons for 20 years. I've seen the big difference that the robotic has made in my ability to train capable, safe surgeons. This is a technology that has, you can do 10 lectures only on the enabling power of robot-assisted surgery. I will be happy to provide all sorts of scientific support to what I'm saying. But again, because this is a practical lecture as well, I want to keep this relatively straightforward. It's also ergonomic. We are facing an epidemic of laparoscopy-related skeletal issues, particularly with pelvic laparoscopy. We're looking at rotator cuff injuries, which often bring excellent surgeons to the orthopedic surgeon because of this problem. So it affects directly, the use of robotic surgery affects directly operator health. This is an eminently patient-centered technology. We have validated simulation for robotic surgery. If you are not familiar with the paper by Patrick Callaghan, the paper that basically has validated the so-called Morristown protocol, I would very strongly advise you to go and read it very carefully, because that is a humbling paper where basically Pat Callaghan showed that you can train robotically naive surgeons to perform as well as experts on their first hysterectomy. This is a beautiful paper that really has changed also the way I run my program at Brigham and Women's Hospital. And basically our program is simulation run, and we run very closely to the practice that the FAA, the Federal Aviation Administration, has put in place over 30 years ago, and is now, of course, the practice all over the world, about the importance of simulation for their pilots. So all my trainees, but also every attending surgeon in the hospital, has to do simulation drills that are, in fact, in a sliding scale depending on their volume at the hospital, for certification as well as for recertification. This is very much patient-centered medicine, because it allows your patient to get a technically perfect surgeon every time. Of course, not all surgeons are the same. Surgery is not only about how you move. It's basically where you move and when you move, so the strategy. But what I can tell you is that eliminating the aptitude barrier and eliminating the learning curve on the technology, it makes a very patient-centered technology. If the patients ever would catch wind of this reality, I would submit to you that we would observe a significant problem for any surgery that is not robotic, particularly in the age of the internet. This is a standardized procedure. Of course, you perform it basically with the same basic steps and with the same equipment in Nairobi, in Rome, or in Dallas. And this is very important, because it also brings, it's very easy for me to share information with you today that you can go tomorrow on your robot and apply it, because we're all using the same thing. And last but definitely not least, this is a digital tool. So we really haven't seen nothing yet. I mean, you're talking about automation, you're talking about visual fusion, and many other things that are yet to come. At this point, what you have observed in the past 4 generations of robots is an improvement of mechanics and minimal improvement in the digital, but the digital is also coming. So this is the surgery not only of today, but definitely of tomorrow. Again, not to belabor the point, but you can achieve technical competence through validated simulation. This is important in the new myomectomy. There is a lot of suturing that goes on, which is, by the way, a very different suturing than what we learn and perfect as conventional laparoscopic surgeons. Is the whole idea of the suturing that's different. The hand you use, the back stitching you use, all of this can be all completely done on a simulator, so that when you hit the patient, you're not training on them. Part of the new myomectomy, as far as I'm concerned, is that the surgeon is responsible for image interpretation. even before robotics, when I was doing conventional laparoscopic myomectomy, I would never approach a patient without an MRI. I've seen patients brought to the operating room and brought out with many fibroids still inside. I've seen uteri butchered because of adenomyosis that had not been identified. I've seen patients diving into myomectomies in situations where they shouldn't have, when they go in and find stage 4 endometriosis, which had not been identified by ultrasound. So imaging is very important, and this is one of the big tips that I would recommend for any surgeon that's approaching myomectomy at this point. And then there is a lot to do with preoperative preparation for myomectomy, and we'll go over some of the things, but I can tell you today that a lot of what I do for successful myomectomies is done before the patient ever reaches the operating room. So in the end, the paradox of today is that thanks to the robot that flattens the aptitude problem and gets you trained, what you have to think about when you have your uterus in front of you at robotic surgery is no longer how to move. This has been our big problem in laparoscopy in the past 25 years, that we have to think how we move. Even when we're really good, when things get rough or when movements have to be very quick, as it is the case in myomectomy, where the time of myomectomy means blood loss by the patient, right? As we all know. We have to do the same procedures that we're comfortable with, but now in a rush. What happens is with the robot is back to basics. You have a knife or something similar to it, and you have to just know how to do the operation, not how to really move your hands. That's the point. We have done quite well. This is an analysis of our first 715 cases, and the problem with this has been that we're now proceeding at such a high pace that we're over 1,000, and we always want to reanalyze this stuff before we publish. But this is stuff that's been already presented at AAGL 3 years ago, 3 sessions ago, and I want to point out right here that these are significant myomectomies. We're not tackling small things. So a 2,000 gram myomectomy is at least 4 times the size of the native uterus, as you know. At least 4 myomas. This is our average. Myoma diameter 7.5 centimeters. All our patients, most of our patients are overweight, as you probably know. The most important thing is here. Look at the broad ligament and cervical myomas. These are complex myomectomies, and yet they make 10%, about 10%, 9% of what we actually see and operate on a regular basis. So if I do 10 myomectomies a month, one is bound to be a retroperitoneal or a cervical myomectomy. In all of this, I want to point your attention to this. We've had one conversion in the past 1,000 surgeries. So this is based on the 715, by the way. But we have like 1 in 1,000 conversion rate at this point. And the rate of major and minor complication is quite low. The rate of blood transfusion, which was 4.4%, this, by the way, includes our entire learning curve. So from case 1, we have not excluded any cases. This number has dropped dramatically because of some novelties that have come, technological novelties that are not related, by the way, to robotic myomectomy, but can be applied to any type of myomectomy, frankly, and we'll go over them. Very importantly here, this is a paper by the late Dr. Pitter. For those of you who have been lucky enough to know him, he was one of the true pioneers of gynecologic robotic surgery, benign gynecologic robotic surgery. And just to put things in perspective, in early 2006, when I decided to jump into robotic surgery, that's the guy I went to see. In any case, he has been a prolific producer in the scientific literature as well for robotic myomectomy. And this is an important paper that we did together as a multi-center study, where we looked at the the reproductive safety of robotic myomectomy. And I want you to focus on, we sent out a questionnaire and there was a good response rate. 50% for a questionnaire is considered a good response rate. The average time from surgery of patients that were polled was 2.5 years. And we divided in order to assess the reproductive outcome in 3 groups. The ones that definitely were not desiring fertility. And then the groups 2 and 3, right here, were groups where they either desire to preserve fertility but not immediately trying to, particularly younger patients, right? Or a group actively seeking pregnancy. This was it was very important. If you can actually focus on this, this is women. These are all women who achieved pregnancy, right? In group 3, this is the women that were trying to achieve pregnancy. We are at 70% at 36 months. So this is a very good number. In a subgroup of that are women that were also symptom-free at the time of the questionnaire. We had 80% that had achieved a pregnancy at 36 months. This number, of course, is never going to be 100%, but 80% is very high. Also, very importantly, it correlates very well with 2 other studies, one by Cella and others, and one by Lonerforce, both of which put out the chance of pregnancy following robotic myomectomy at about the 70 to 80% mark. If you know the literature about laparoscopic myomectomy, the largest study, the Italian multicenter study of 2007 by Ornella Sizzi, which was a great study, by the way, even though it had a less clear denomination of intention, it was done at a time where myomectomy was only offered to women that wanted to complete childbearing. So this would be an average of the groups 2 and 3 in our study. And the pregnancy and the follow-up was only 22%. This is an even longer study. It's a 7-year follow-up from laparoscopic myomectomy. And this is a Canadian study. And in the 7-year follow-up, they have a 40% pregnancy rate. So, of course, you can never do, that's why we have meta-analysis that do this and weigh the studies. I'm fully aware of that. But I just want you to observe the trend. The trend is for literature to produce a high rate of high success in terms of reproductive success compared to even laparoscopic myomectomy. And that basically is because there is laparoscopic myomectomy and laparoscopic myomectomy. And, and we have to be very clear what we are defining and what we are telling the patients that we're doing, because the patients don't expect a streamlined, simplified myomectomy. There is only one myomectomy, and if you can do it laparoscopically, that's great. Otherwise, you gotta open, or you can use a robot. I was being funny here when I say tasseography. Tasseography, as maybe some of you know, it's the ability to tell the future by reading tea leaves, which is Eastern art. But to me, ultrasound for big fibroids, that's exactly what it is. You know, just thinking that you have achieved any type of imaging for big fibroids with a pelvic ultrasound is just wishful thinking. You have to use MRI, and it's all the time worth the extra money and the extra effort from the patient, because this is the same patient, by the way, with ultrasound and MRI, and this is how we plan our surgeries, and this is frankly also with the help of the robot how we have opened only one patient out of 1,000. So when we go in, it's not to try. We go in to finish the myomectomy robotically, and imaging is a big part of it, I have to tell you. For example, these are uteri that we would easily tackle robotically. You know, you can count all the fibers. These are out, easy to grab. This one is attached to the base of the largest one. This is fundal. This is very large, degenerated posterior, is stretching the cervix, but still doable. Whereas, for example, most of us would probably not tackle something at 25 centimeters, goes into the chest and is attached to the lung. And this one is what we call a bag of marbles. That is like a bag of stones. You will never be done laparoscopically with this. This is probably at 2.5, 3 hours open myomectomy and over 60 fibroids removed. So these are the cases that we select out of our operating room. I want to spend a few minutes on our port placement. Our port placement has been traditionally very different from what most centers do. Of course, I've trained enough people now that a lot of surgeons are doing this, but my port placement with an assistant port, the yellow port in the right lower quadrant, comes from my being a classically trained advanced laparoscopist. So this is my vertical zone, and particularly for myomectomy, I like to have this. There are some stretches, when the fibers are really too high. Remember that the robot is a 2-quadrant operator. Even the new robot is a 2-quadrant operator. Of course, you can change the angle, of the robot and point upward, but still, it's not like something that there is a limitation to the robotic movements. Whereas you can do any laparoscopic part of the operation that you need to prepare for a more successful robotic part, or you can have it at the end to help you in your placement of the specimen in a bag for extraction, for example. But also, and more importantly, you are able to have the passage of needles, which sometimes we use 10, 15 needles for a big myomectomy, to happen always in front of the camera. This is very important. Also, think about it. If my assistant port is caudal, is medial to the anterior superior iliac spine, first of all, if you're interested in in the cosmesis of this, you're sparing a visible scar to the patient, because otherwise they would have it right here in between, right? So you're sparing a visible scar to the patient, but also you are helping the assistant, because the assistant is going to have to maneuver this as well as the uterine manipulator, which is down here. So you're helping the assistant stand on one side of the patient that is away from the action that happens up here with all the robotic arms. So the assistant stands at bedside. It can manipulate the uterus from down here with the left hand, and with the right hand, and with the left hand it can assist at bedside through the assistant port. So that's why I have it like this. And you notice that you have a classic where you have two instrument arm, a camera arm. You have all four when you use all of your instrument arms, and of course you can invert this on the x-axis, and so you have these two robotic here, and you have the assistant port on the other side. You can also have, sometimes solo surgery, and you don't need the assistant, so you just do without the assistant port, and all you do is you remove one of the robotic arms when a quick assistance is needed. You can load the sutures from a umbilical port if you do a 12, and you can also do a 12 with the XI, remember, because they have a reducer. And these are important additional technical considerations. I think these are the reasons we don't have much bleeding anymore. And it's been over 3 years now that we haven't transfused a single patient. And we used to have a 4.4 chance of blood transfusion on this myomectomy, which is more like the market standard. But basically at this point, we only use barbed suture. We've done so for many years. We use vasopressin, and I know that in many European countries, vasopressin is not used. If you have it legal where you work, of course you should use it. But if you don't, you definitely don't want to miss using rectal misoprostol or tranexamic acid. Tranexamic acid is very important, particularly in patients that are coming to the surgery on borderline anemia, or patients in which you notice right away that as you're cutting, this uterus is bleeding more than normal. Tranexamic acid, 1 gram IV, should be given by the anesthesiologist and should be discussed before the surgery so that they have it handy. We do use GnRH agonists in depot form in select cases. For example, the most common case where I would use this would be somebody who is both anemic and has very large fibroids. So I kill 2 birds with 1 stone. by giving them 3 months of depot luprolide or similar, which will slightly shrink my fibroid up to 30%, and definitely raise my hematocrit to male values, so 42, 44%, so that even if they lose 500, 1,000 cc's of